up next, I don't know if you've got to meet her yet. She was our official airport greeter just yesterday, and I had several patient advocates who got off the plane saying they have never in their entire lives felt as welcomed as they did to this event, and it is because of JARI HOLLAND BUCK and how amazing and empowering and kind she is. She's a spectacular patient advocate. I had the honor of meeting her. Before I met her, I painted about her back in 2010 in a really big painting called Give Us Our Damn Data. That's D-A-M-M-E-D, because I don't cuss, so it's like blocked up. So with no further ado, because she's been waiting so patiently, thank you so much, JARI.
Good afternoon. There is the time before, the time during, and the time after. And for any of us who have lived through a catastrophic personal medical situation, that is now the way that we clock time. And mine occurred on October 23rd of the year 2000 when my husband was admitted to the hospital for what was supposed to be a routine pancreatitis episode, and it lasted 9 months, 6.5 of which were on full life support. What I did at that point in time is begin asking questions about why did this happen? And some of the answers I came up with at that time, as well as answers that have occurred to me since, are things like, my whole life built up to this. The part that says that it's important that I share how we got through this, both the hospitalization and the aftercare. The part that says silence and acceptance is no longer a safe place to operate from when we go through an emergency medical situation. And the time that ultimately says, I'm fulfilling my mission, finally in life. I've been asked by a couple of people to explain the significance of my jacket, which I do not have on today. But my jacket's title is Signs, and the nature of that particular title came from the fact that 2 weeks before my husband was hospitalized, a barred owl showed up on our back deck. And I don't know how many of you know this, but owls in much Native American tradition portend death. And this was clearly a sign to me of things that were coming. And for those of you who have been through this kind of situation, you know that it's critical when you have a hospitalized patient to monitor their signs as indicators of what's going on inside of their physical body. So Regina's portrayal of signs became an absolute hallmark for me in terms of talking about our experiences. Anytime I do a presentation that includes a definition of some kind, I always go to the dictionary and look up what it means. And in this case, signs had a number of different kinds of definitions, which maybe we'll see and maybe we won't. There we go. And throughout my presentation, what I'm going to be doing is indicating which of these definitions are the ones that are critical. And for me, the appearance of the owl was a portentous event or incident, something that predicted an upcoming experience that was not to be particularly positive. Now, when you look at a medical or a disease state, the definition of signs that we're looking at is the one that you see indicated in red up here. And my husband had a disease called necrotizing pancreatitis. Are there any medical practitioners in the room? Okay, from your experience, what do you know about necrotizing pancreatitis? Yes. Yes. Yes, that's correct. His pancreas was dying, it was self-destructing, and the nature of the disease is what happens when the entire organ self-destructs and sends itself through the body. And the surgeon who ultimately operated on him and saved his physical body said that necrotizing pancreatitis is the sickest that a body can get and still be alive. So rather than me telling you my story today, what I want to share with you is the results and the learnings that came from the story. But in order to do that, I think it's important that you understand what happened to this man's body and what the two of us lived through over a 9-month period. So here are all of the events that occurred during his hospitalization. And as you see up there, based on all of those events, a single one of those events I could spend my entire 45 minutes talking about. So that's why I've chosen to share with you the learning as opposed to the story. What's important for you to understand is that I wrote this presentation from the perspective of being the advocate, because that's what I was for him. And that's also the perspective from which I wrote the book. For those of you who are not in an advocacy role, but rather in a patient role or a family member role, it shouldn't take too long or too much effort for you to transcend this and to make it into something that's workable for you. The other thing that I want to say is this is a pretty extensive PowerPoint, and I don't know about you, but I teach for a living, and when I do PowerPoints, I hate it when the people don't give us copies of them, because then I'm so busy trying to capture what's said. So if there's anyone who's interested, at the end of this, I will give you my web address and you can contact me, and I'd be happy to send the entire PowerPoint to you so you can just kind of sit back and relax and think about what we're talking about here. One of the things I thought it was important for us to look at is what are the signs of partnerships with patients, since that is the whole context for our presence here. And I like to illustrate it as a three-way relationship, and that's why you see the tripod here. And the three-way relationship, one of the legs stands for the patient-family combination, one of the legs stands for all of the healthcare providers unified, we hope, and one of the legs stands for the advocate. Now, how do we know when that's working? Some evidence of this actually working looks like this. The doctors actually talk willingly to us and to the patient about what's going on. That's a good sign. The doctors answer questions that are posed by us or by the patient. And additionally, nurses readily provide education to us when asked, and sometimes even when not asked. So, you look at this and you think, as I did, because it's been 12 years since I went through this, are there any signs of improvement in this tripod relationship? And I will tell you that just last Wednesday, we had a joint commission publication, and here is the web address for it. And what this joint commission publication talks about is health and safety markers that are improving throughout the hospital systems in the United States. So, the good news is they're tracking it. The bad news is how accurately is it being performed? How accurately is it being reported, and what are the issues that continue that are not being looked at that are indicators of safety? So bottom line, what we're trying to do is get into a prevention mode here. And so when you talk about prevention, one of the best quotes that I ever found for prevention came from a very spicy, dicey reporter by the name of Bernard Levin. And he talks about prevention as being a long-term process, which is why I like this particular quote. Because in the case of healthcare, given the situation that we've all faced here, we are looking at a long-term situation to get into a preventative mode. So, as Bart did previously, this is a quick preview of my 20 slides in 5 minutes Ignite speech tonight. For me, the most important thing about prevention deals with hand hygiene. My husband's brain was lost to a MRSA infection. So even though his body survived, his brain did not throughout this hospitalization, even though he survived a catastrophic illness process. So tonight in my Ignite speech, I'll be talking about these 3 steps and why I think they're important to prevent contracting hospital-acquired infections. Additionally, there was a study that was just reported this past week. I follow the medical boards. And this particular study looked at a hospital in Geneva, Switzerland, where they got responses back from about 1/3 of the doctors and nurses that were surveyed. And what I found interesting about this study, which you're going to experience if you promote any kind of prevention, specifically hand hygiene, is that about 1/3 of the respondents said that they didn't want to be reminded to wash their hands because they thought it could be upsetting or humiliating. And I think to myself, okay, upsetting and humiliating or MRSA? Upsetting or humiliating or Clostridium difficile? Upsetting and humiliating or death? Those all seem to me to be very easy decisions to make. Very easy decisions. One of the other things this particular study showed was that 37% said they would not consent to wearing a badge, encouraging patients to ask them about hand hygiene. So for me, those were frightening statistics, particularly given my experience. What you will find, particularly around hand hygiene, is that oftentimes people will approach the bed, and as I'll speak about tonight, the minute they touch your patient without performing hand hygiene, it's over. So what I encourage people to do is to make this comment before someone gets to the bed. And then, oftentimes, what they will say to you is, yeah, but I washed my hands outside the room. Yeah, but I sanitized outside the room. In my experience is if you haven't seen them do it, assume they haven't. So in that situation, what I will say to them is, you know, my experience is that C. diff responds better to hand washing and MRSA responds better to alcohol. So I'd really appreciate it if you would do both of these things. Quite often, they will say, oh, okay. They'll do it, and then, as I had a surgeon do to me, he'd finished the hand hygiene and he picked up his phone and answered it. What do you think I said to him? Go back and do it again. Go back and do it again. Okay? So, in this situation, what I recommend that you do is if a healthcare worker says, no, I will not clean my hands again, ask them to step outside the room, contact the head of nursing, and ask the head of nursing to take care of it. Because in this situation, hospitals are concerned about the passing on of hospital-acquired infections, and that's probably and absolutely the safest thing that you can do for your patient. Now, when I finally emerged from the catastrophe that befell my husband and I, and started thinking about the things that were important for me, I realized that there are 6 fronts where it's critical that we attend to our own health as well as to the patient's health. The first one is at home. And I have 5 dogs at the time. My husband and I didn't have any children living at home. This was a 9-month protracted experience. We clearly had to get someone to take care of the dogs in the home. During that period of time, there was an attempted burglary and a break-in to the car that was parked in the parking lot. And this is with daily activity in the house. But it was real clear to anybody who was watching the house that it was not being occupied. Second place where you have to take care of yourself is in the hospital. You have to make sure you're hydrated. You have to make sure that you do your own sanitizing to protect yourself. And those are all critical factors. The other factor that a lot of people don't think about is security. What happens when you're distracted and you're walking out to your car and you're not paying attention to what's going on around you? You are a potential victim. What happens when you bring in an expensive piece of electronic equipment? I can tell you that there were at least 4 incidences reported to me where that equipment got up and walked out of the room when the patient or the advocate was not present. So taking care of what's going on in the hospital is critical to you as well. Physically, I always recommend that folks try to see if the hospital will allow you to join their health club. They almost all have one for physical therapy. So see if you can't become a member there. At a minimum, go outside, see the physical world, because it's not just the patients who suffer from sundowners. It's also the advocates and the family members who are 24/7 in the hospital room and can't get out and lose track of what time day or night is. Additionally, emotionally, all of us are affected by being around a critically ill person, especially if that person is someone that we love and care about. We get frightened and afraid, and we need to take care of our own emotions. I had to lean on friends. It's always advisable to have a trusted medical advisor who is outside of the treating physicians so that you can bounce ideas off them and ask them which of these treatments do you think sounds best. And the other thing I found in a hospital, specifically when a patient is on life support, is it's very noisy in the room. And so a lot of times I recommend to folks go find the chapel. Even if you're not a religious or spiritual person, the chapel is the one place in the entire hospital where you can pretty much be guaranteed where it's quiet. And that will enable you to get away from that background noise that becomes problematic. Regardless of your spiritual practice, when you're in a hospital, the minister, priest, rabbi, imam is going to come and talk to you, see what kind of spiritual support you're looking for, share with them, and talk about what's important to you and what's important to your patient. And then, of course, psychologically, it's very important. And what I knew is in the hospital, it was important for me to be anchored psychologically. What I did not recognize for a long period of time until after the hospitalization and 6 years of care, I did not realize that I was suffering from an extremely severe case of post-traumatic stress disorder. And that's not something that many of us think about in terms of caring for a loved one, that we could be the victim of PTSD. And when a friend of mine suggested I look at that list, and I went down that list and went, yes, 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 I realized that that psychological self-care was something that was critical not only while I was in the hospital with him, not only immediately after his discharge, but also quite a bit of time after that, because I had been 100% focused this way and very little, if any, focused this way. Another recommendation that I make to people is to choose your hospital extremely carefully. And I don't know how many of you are aware of the different types of hospitals that exist out there. There are a couple of differentiators that I can talk about. The first one is the difference between private hospitals and teaching or public hospitals. And you'll see the comparisons that you have here between the two. There's a substantial cost difference. Quite often in a private hospital, at least in my experience, more so than in a public hospital, you'll have the presence of a hospitalist which is kind of the hospital doctor who's supposed to make sure that all the doctors talk to each other. Supposed to is the operative term. The other thing that I found quite often in a private hospital is that the doctor who was treating my husband on a Monday through Friday was not the same doctor who was treating him on the nights and the weekends and the holidays. Instead, I got partners of that doctor's because they rotate through the practice. Additionally, today, many hospitals are owned by private medical practices, particularly in the orthopedic area. And what we know from many, many studies is when a medical practice buys a piece of equipment or erects a hospital, guess what happens? The usage rate goes up dramatically because they have to justify the expense. Is that the kind of situation that you want? And the answer to this will be different for each of you. When you get into a teaching or a public hospital, which is a lot like a university hospital, what you're going to find is the costs are lower, but what you have, much more so in my experience than in the private hospitals, is you have body part specialists. And you also have rotations of doctors that are different. So you may get the same treating physician for a particular body part Monday through Sunday. In fact, you may get it 4 weeks in a row, Monday through Sunday. And at the end of the 4th week, bling, the entire practice rotates. You get a totally different specialist on that body part with their attending and their residents and their interns, and you get to start all over again explaining what happened. And they don't know the history of your patient or how to bring together all of the pieces, interestingly enough, of even some of their partners who have gone on before. So continuity of care becomes a real issue there. And oftentimes I found myself alone much more there than I did in the private hospital because of the existence of the hospitalist. The other differentiator that I want to point out is the age of the hospital. And what we know is that the older the facility is, the more resident germs are present. So, all things being equal, if you got a new hospital versus an old hospital, you ought to pick that new hospital every time because you do not have the resident germs that are present from the length of time that that older facility has been occupied. And maybe all the house cleaning and housekeeping hasn't been quite the way you'd want it to be. What I also find interesting, particularly about family members or people who know that they're going into the hospital ahead of time, is that many times they don't do their homework. And this particular quote is really interesting because it not only gives us information about a hospital and the need for investigating hospitals, it also tells us that different doctors, particularly in a surgical situation, have to be researched. So what we're being told here is we need to research our hospital ahead of time. We need to research our primary care physician or whoever's going to be the primary treating partner. We also need to investigate our anesthesiologist, who is responsible for our breathing and our consciousness and our unconsciousness when we are going under the knife. So what I find amazing is that oftentimes that's not done, and in some cases it's not done because people don't know where to go to do the research. So you guys are all internet and technical savvy. You can do your own research, but here are some of the sites that I came up with in terms of doing doctor research and in terms of doing hospital research, as well as that JCHO safety study that just came out that I referenced in an earlier slide. The next thing I always recommend to people is if you're not in an emergent care situation, pick the days of your stay very carefully. Anybody know what's the worst day to be admitted to the hospital? Friday. Why? That's right. They're going to do their diagnostics on Friday, then that entire crew is going to disappear for the weekend and show up back on Monday. And what's happening over the weekend? Yeah, you're disintegrating, you die, or they're in a maintenance mode. They're just trying to keep you viable as a patient until Monday when all the normal people come back. So it's always better to choose elective surgery, if you have a choice, on a Monday, because then you got 5 days to do recovery and you hope that you can escape from the hospital setting before Friday night, because otherwise you're in a maintenance mode. And if there's any question, ask if you can't take your patient home and maintain them over the weekend, even if you have to bring him back, because that's likely to be a lot safer at home than it is being in the hospital. Why is that the case? Because during nights, weekends, and holidays, we have the least senior staff. All of the senior nurses choose to work Monday through Friday days, which means on nights, weekends, and holidays, we have a less experienced crew. In addition to that, you've got the doctors rotating. Oftentimes in a public setting, you have residents caring for your hospitals, and you may not get the primary partner who's taking care of your patient. So you are clearly vulnerable at a number of levels if you end up having to spend time over nights, weekends, and holidays. I wanted to just briefly tell you one of the experiences that Bill and I had was over a Mother's Day holiday, and he was in the rehab facility of the public hospital that he was in locally. By the way, I'm local. And he was being treated by a single nurse who had one care partner, and there were 16 patients for a 12-hour shift. One nurse, okay? Now, there was a study that was done out of the University of Pennsylvania that said for every single patient that is added to a nurse's care above four patients, you increase the likelihood of injury or harm by 7%. What that means, bottom line, is on Mother's Day of that particular holiday, my husband was 84% more likely to suffer harm or death because of the nurse-to-patient ratio. What was interesting about that particular Sunday was that on that Sunday, one of those 16 patients coded. And the responsibility of the nurse during a code is to go with the patient and stay with the patient until the patient either stabilizes, is readmitted to the hospital, or passes. She was off the floor 3 hours. Who was caring for those other 15 patients? I know who was caring for my patient because I was there, but there were 14 other patients that got no attention for a 3-hour time period. I don't want to beat a dead horse here, because our two previous speakers did an exceptional job talking about the need for advanced directives. I do want to state that the advanced directives that I am aware of oftentimes don't include this last one, which is the out-of-hospital do not resuscitate order. And that is the advanced directive that is critical for you to have and give, if your patient is a DNR, to the emergency response team that's coming in an ambulance to pick up your patient, because they are obligated by law to resuscitate. And they do not honor in-hospital DNRs because you're not in a hospital. So if you do not have an outside the hospital DNR, even with an in-hospital DNR, if your patient codes and flatlines, they will be resuscitated, even if it is directly against their will and their personal desires. So at a minimum, you need to be looking at these 4 documents as a total part of your experience in creating your advanced directives. Now, a couple of things that I found. Every time Bill got transferred to a different unit, they misplace his advance directives. So I carried 20 advance directives with me at all times, and every time he was moved, I served them again. Now that was in spite of the fact that I contacted risk management, and risk management's attorney came down, and I served them with his advance directives, and I made them sign a form saying, I have received his advance directives. But it was interesting because they never followed him from unit to unit to unit. So do not assume that there is a handoff that is adequate when your patient moves from one situation to another. The other thing that I want to talk to you just briefly about regarding advance directives, because I think we are in the midst of absolutely ground-shaking changes. For any of you who are interested, I would recommend that you Google a particular woman who is my mother's former elder law attorney. Her name is Susan Elizabeth Van Note, also known as Liz Van Note. As far as I am aware, this is the first time where there has been a first-degree murder charge pressed against an elder law attorney for death by advance directives. Miss Van Note is an elder law attorney who makes her living preparing advance directives. She allegedly went down to Branson, shot and stabbed her father's significant other. She died. Shot and stabbed her father. Incidentally, she's the only recipient in his will. Okay? Only her father didn't die. So he was transported on an emergency basis to an adjacent county where they had a level 1 trauma center, and they determined he had to go on full life support. And she goes, oh shucks, he's still alive. So she goes back to her office, creates and forges signatures on a durable medical power of attorney and a living will, giving her the power to make advanced life support decisions, and saying that he allegedly did not want to be resuscitated. She got them notarized by 2 people who are now also in jail, and she served them on the hospital, and they removed him from life support. So this is just emerging right now. It's only a 2-week-old situation. It has not gone to trial yet. It took 2 years to get her to prison because there were 3 jurisdictions involved, and she was an elder law attorney. So I'm reasonably certain they would not have arrested her if they didn't have some pretty compelling evidence. So I would urge any of you who are interested in tracking the law, specifically as it relates to advance directives, to keep an eye on this particular thing. Now, what are the signs of advance directives being present? So first of all, here's the definition of signs that I chose. The first thing I will note is that when the doctors walk in, there will be a big DNR posted on the outside of the file, and no matter how far away you are, it should be distinctive enough that you can see it from across the room. The second thing that tells me that the advance directives are there is that I want to verify executed copies go to hospital legal. And I also want to create a proof of service document. Now, I had a devil of a time finding a proof of service document because if you don't know, advance directives are legislated state by state. So I live in a bi-state area. Fortunately, they honor reciprocity. But if you have the misfortune of being in California and your advance directives were executed in Kansas, there is a very strong likelihood they will not be recognized and they will not be valued. So you want to make sure that you have advance directives that are consistent with the particular state that you're in. So this is where you get a proof of service document. But what I would recommend that you do if you don't have an attorney is go to the recommended website here, put in your state, and up will come some generic advanced directive documents that you can execute. In addition to that, your local hospitals will all have advanced directives as well. And you can execute them, although they tend not to have as much teeth, of course, because they still want the doctors to have the power to make the life and death decision, and they're not as willing legally to turn that responsibility over to someone else. Additionally, some hospitals do, oh, and I will tell you, carry extra copies with you. And some hospitals today are embracing the use of DNR wristbands. Anybody know what the DNR color is on a wristband? Purple. Purple wristbands is an indicator of a DNR executed and on file. Okay? All right, so after we take a look at that, it's important to recognize that there's a whole lot of places where you can search. There's information on executing DNRs in addition to the information from the prior presentation here. And there's information here regarding the forms that are available to you. How many of you in here have executed on file advanced directives? Okay. I'll be happy when I see all the hands in the room go up. Every hospital that you work with is going to have a patient's rights statement. Who do you think wrote the patient's rights statement? The lawyers did. And do you think the patient's rights statement is really written for you? No, it's written as a direct result of local and national lawsuits that have been filed. So what I tell people to do is get that patient's rights statement, and anytime anyone is challenging you about what you can and cannot do, either as a patient or an advocate, or what your rights are, represent it to them and remind them that you have a right to this. And I probably had to do that, I don't know, 60 to 100 times over the course of a 9-month hospitalization. The other thing that I think is very important is to make your patient a real person. Oftentimes, especially in public hospitals, the patients are body parts. So you have a nephrologist come in and all they're interested in is a kidney. Or you have a cardiologist come in and all they're interested in is a heart. And the reality is this kidney and this heart live inside of a real human being. And because my husband was anesthetized into unconsciousness for 6.5 months, the majority of his healthcare providers had never seen him upright and conscious. So I brought in pictures of him when he was a viable human being, hanging out with his mother, hanging out with his kids, playing with the dogs, going on vacation, to let them know that this was a real human being that they were dealing with. And that seemed to make a difference. In fact, so much so that I had a number of nurses and doctors say, wow, I've never seen him vertical, because they'd only always seen him horizontal. It's important to recognize that people, patients, can hear everything that is being said in their space, even if they are not conscious and are unresponsive. And how do I know that? Well, since my husband was anesthetized into unconsciousness, he was being monitored. I could see his breathing, his respiration rate, I could see his heart rate, and when an upsetting encounter during which he was unconscious occurred in his room, what do you think happened to his respiration and his heart rate? It increased. This guy is unconscious and drugged into unconsciousness, and it spiked. So in the early days, I didn't know this until I started watching the monitors. And then afterwards, I realized I can't have those conversations in the room because he understands what's going on. At some level, he's responding to this. And so what I had to do is ask healthcare providers to have the conversations outside the room, especially the conversations where the nephrologist said your husband has less than a 5% chance of his kidneys ever coming back online, or where a major medical center that's in a northern state that we all know said to me, take him home and let him die. I asked the physicians to have those conversations out in the hall. If they refused, I took them off his case. And you have the right to do that. You can remove physicians and nurses from their cases. It's important for you to understand that everything that is going into your patient is necessary for you to know about. However, having said that, you have to be really cautious about how many questions you ask. So I oftentimes went with my list of 100 questions to the nurses and said, how many of those can you help me with? And then left the ones that I didn't understand or needed more explanation to the doctors. And the statement that I used that I found helped me a lot is I'm using this term intentionally, subordinate to them by preceding my questions with, can you help me understand? Which made it not so challenging. It was an acknowledgement that I didn't have the same knowledge level that they did, and that they then could share that information with me. And I never had a doctor refuse to talk to me, nor any of these other sources that are available to you inside of hospital settings. So while you're in the process of educating yourself, you need to educate yourself about every medication, anything that is going into the body of your patient. And any one of you who are nurses know that there are 5 rights of medication. Some say there's 6, some say there's 7. But these were the first 5. They are abbreviated with the acronym PDART, and they stand for patient, drug, amount, route, and time. And every time something's going into a patient, you have to ensure that all 5 of those things are correct. So how do you do that? I placed a poster over his bed. And on that poster, I wrote down his name, his room and bed number, his allergies, any chronic conditions, and any impairments that he had. And I also kept track of line changeouts, which are one of the primary sources for hospital-acquired infections. And most hospitals will change 2 to 3 days out every time an IV needs to be changed or some such thing. So what you should do is ask them, what is your lane changeout policy, and then make a note and track when they changed it out and when the next line changeout is due. And I would say I probably had to tell the facility who had informed me of what the line changeout dates were at least 50 times over the course of a 9-month hospitalization that today was the day that they needed to change out the line. And this was after he had had 3 codes as a direct result of infections that were coming through IV lines. In the same way you need to understand what's going in, you also need to understand treatments. And I did so much research on the internet that frequently the doctors would say, could I have a copy of that? I need a copy of that article. I'd like to update my knowledge and understanding about this. So I always encourage people to act like a reporter and ask all those critical reporter questions: who, what, when, where, and why. And irrespective of your spiritual practice, I would suggest to you that you look at prayer as a tool that you can use. Now, I'll back up here and briefly let you know that keeping track of supplies is important because until 2013, we all have a lifetime maximum on our healthcare policy, and you can lose coverage. And these were some of the overages that we experienced. In addition to that, posting an advocate in their room 24/7 is critical. Obviously, you can't do that. What you'll see here is a quotation from Steve Jobs and his wife about the necessity for 24/7 coverage. So what you do is you play tag team. And I created something called a Care Team Notebook, which you can download off of my website, that'll enable you to track what activities have occurred in each of the situations where you've had a different advocate here. So keep track of this stuff, but recognize your primary advocate is the glue that holds this whole team together. I indicated prayer is an important tool. And I will tell you that there are studies that indicate that prayer has an impact on patients even though we don't understand why. What I can tell you from personal experience is that I asked my mother-in-law's prayer group to pray for my husband, and his organs came back online in direct order of the prayer group. I would say to them, pray for his kidneys, kidneys came back. Pray for his liver came back. And that was the way we brought him back to functionality. After you pray and have done all of this thing, you just got to let it go, because we're responsible for the input. We're not responsible for the outcome. And I think it's important also to recognize that taking care of yourself is the pivot point for all of these. And that sacrificing your health is something that nobody who cared about us would want us to do. Whether you are a patient, a healthcare provider, or an advocate, never give up. The outcome may not always be positive, but that doesn't mean that there aren't things that you can do to assist whatever is going to be the outcome. And if nothing else, it's sitting by the bedside and holding someone's hand. And I mean by the bedside and not on the bed, and we'll talk about that tonight in the Unite speech as well. All of you are here because you have the same passion that I do, and I bow to that passion. And if you can let that inform you as it relates to the specific techniques that I've shared with you here that I learned in our 9 months in the healthcare situation, I think it will help you and your patient immeasurably. Any questions, comments, or signs that you want to share? Thank you. Here's all the contact information. If there is anyone who is interested and didn't grab it, I have postcards up here, and they also have my email address on it, and you're welcome to take one of those. And that's the way you can contact me to gain access to the PowerPoint. So